To discuss the important subject of decongestion in patients with heart failure and chronic disease. Use the QR code to enhance your interactive learning opportunities this morning. Here is the QR code for your scanning pleasure. I am Harriet Vansball. I'm a cardiologist and senior scientist at the Population Health Research Institute in McMaster University in Canada, and it's delightful to be here and thaw out. I come from minus 25 degrees Celsius weather, so this is wonderful. I am delighted to have with me Professor Amir Kazouri, who is the Robert Cade Chair in Nephrology. And we are here to talk about the heart-kidney connection. Heart failure and chronic kidney disease are inextricably linked and perpetuate each other. Vascular disease, comorbidities such as obesity, and more specifically, visceral adiposity, hypertension, and diabetes increase the risk of cardiovascular disease and heart failure, as well as kidney disease via systemic and endothelial inflammation. Heart disease then potentiates kidney damage. Heart failure can change glomerular structure and decrease GFR via both neurohormonal activation and hemodynamic changes, which include a reduction in kidney perfusion and an elevation in renal venous pressures. Kidney damage then worsens heart damage through the increase of LV mass with concentric remodeling and hypertrophy, and a sequential increase in LV and diastolic filling pressures, and the cascade continues on and on. These are data from a pragmatic clinical trial that I led, demonstrating two important points. Kidney conditions coexist with cardiovascular conditions. So among 4,441 patients enrolled in a heart failure trial, close to 80% had hypertension, more than 50% had diabetes, and around 25% had clinical diagnoses of chronic kidney disease. The existence of kidney disease at presentation among patients who have an index diagnosis of heart failure portends a 55% greater risk of death after adjusting for important comorbidities and demographic characteristics. So at 5 years following diagnosis of heart failure, 81% of patients with kidney disease at baseline had died, as compared to 62% of patients who did not have kidney disease at baseline. So kidney disease is a high-risk condition among patients with heart failure, and both diagnoses share common underlying mechanisms. There's a reduction of GFR, an increase in sodium reabsorption, activation of RAS and sympathetic nervous system, an increase in renal venous pressure, and then resistance in BNP and congestion in kidney dysfunction. And in heart failure, as I mentioned, you have an elevated LV filling pressure with volume overload, pulmonary pressure overload, and a right-sided elevation in pressures. All of these culminate in a cascade of neurohormonal sequelae that increases the BNP, decreases urinary sodium, and then have the presentation of right-sided congestion that we see in our patients with heart failure. Congestion is a high-risk state. These are our recent publications in New England Journal Evidence, where we showed that across registries and clinical trials in heart failure, just the act of increasing a diuretic, even in the ambulatory setting through oral diuretic enhancement, is associated with a 3 to 5-fold increase in death. It's not the diuretic enhancement that portends the risk of death, but the congestion that causes us to increase those oral diuretics. So when a patient presents congested and you find yourself increasing diuretics, mark that patient as one who requires close follow-up and care to reduce the risk of all-cause death. Amir?
Okay, good morning, everyone. Before I start, are there any nephrologists in the room? Oh my God. Okay. Oh, there is one. Perfect. Thank you. So it's my pleasure to be here. As Professor Vanswal said, I am a nephrologist here at the University of Florida, here meaning in the state of Florida, but north of Florida. So it's a pleasure to be among you and also share the podium with an internationally known cardiologist as Professor Vanswal. So this is a clinical case. Why do I put this in? It's not because there is anything special about this case. It just reminds you of what kind of person, what kind of patient we are talking about today. So we are talking about a 74-year-old gentleman who had HFrEF, ejection fraction around 30-35%. He has CKD stage 4, and you remember that stage 4 is GFR around 15 to 30, 15 to 29, right? So it is considered advanced CKD. Hypertension, diabetes, and atrial fibrillation. Medications, as you expect, are the sacubitril valsartan, ARNI, low dose because of the blood pressure, metoprolol, as well as torsemide, 20 milligrams once a day. He is not on spironolactone or empagliflozin because of the medication effect, would say. Apixaban for the AFib. So medical history, I talked about the presentation part is that he comes to see you for a routine follow-up. It's not an ER setting or anything. He comes to see you and he tells you that for the past couple of days or a couple of weeks, I have started to have worsening congestion. The exertional dyspnea has been increasing. The class 2 has gone to class 3 and I have gained some weight. Okay, he's otherwise functional and like all of us doesn't want to go to the hospital. The vitals are fairly stable, the same things that in ADHERE registry, if you remember all the 150,000 patients they looked at. We nephrologists, because when we get the consult, the blood pressure is in 90s over 60s, we always think, oh, low blood. No, actually most of the patients have very stable blood pressures when they are admitted to the hospital or at least we get consulted. And the weight has gone up about around 2 kilograms or 4 pounds. Physical exam, as we expect, shows a little bit of a JVD. There are some crackles in the bases of the lungs. And you have, if you, I don't know how many of us go and take a look at the liver and all those, but if you do it, you will see that there is a hepatojugular reflux. Labs, creatinine seems to be at baseline. Baseline is around 2.6, 2.9, and he's 2.8. Sodium is good, a good marker of which way he's going. Sodium, serum sodium, you remember it very well. BUN the same way. You remember that in heart failure, BUN and creatinine are not married. BUN goes up. In acute heart failure, creatinine not as much. So BUN, we look at it really carefully when we see a patient with, and many of the studies that were looking at diuretic resistance, they looked at BUN and creatinine. Creatinine didn't pan out that well. BUN was a good marker for them. Anyways, GFR is good, CO2 is good. He's not intravascularly volume depleted as shown by high bicarbonate levels. NT-proBNP is on the high side. Baseline is 2400, he's at 3200, and hemoglobin is stable. So, in short, the patient has HFrEF and advanced CKD, has some congestion, hemodynamically stable, renal function at baseline, but he's at risk of diuretic resistance. Okay, the question would be, should we act early or should we just be worrying about the worsening renal function? Have you heard of renalism, right? Renalism is when you are so worried about the kidney that you don't do the right thing. It is true, it is the real, Google it. It is the reality is that, you know what it is? It is when you don't do the cardiac cath thinking that, oh, the kidney. Right? That's when you need the cardiac cath, but you don't do it. Anyways, the question would be, you would like to go for it, or I should say?
You go for it.
Okay. In this patient that I just presented to you, do you think the NT-proBNP has any meaningful impact? Please try to answer, and then we'll continue.
It's audience polling.
I hear the yes, and now here we are. 78% said yes, 22% no. I don't know what is the exact answer, to tell you the truth, but I tell you what is in the literature, you pick. So what we know is that obviously, there is some cutoffs for BNP and NT-proBNP, HFrEF or HFpEF. Around 100 and 360 for HFpEF and a little bit higher for the HFrEF, 150 and 600. But we all know that with declining renal function, these levels will go up, right? Because they get less filtered. Would you agree with me? No, they never get filtered. These are peptides. They get transported by active transporters in the tubules. When you have a lot of creatinine, it competes with these. So the creatinine will be transported, not these ones. So they go up on the serum, right? So they go up with the CKD. The question is how high? We don't have a good number, but one study that I saw, and I think it's a reasonable one, tells you that if BNP is over 200 and NT-proBNP is more than 1200, it's meaningful. One quick question. Both of them are the same peptide, 108 amino acids. How come one is much higher than the other one? They are produced at the same rate. Because NT-proBNP is cleared more by the kidney compared to BNP. So it is get affected more by declining GFR. Just keep that in mind if you are interested. So personally, I look at BNP more often than proBNP, but anyways. So in this patient with heart failure and CKD, which loop diuretic would you use? Remember, this patient was on torsemide. It's a polling.
I feel like we need some background music here. Okay, it's a split.
Perfect. Well, again, this is another question that I don't know the answer to. You know, the guy has put all the questions that he doesn't know how. So the reality is that this is what is in reality. We all have our own habits and we go by that. But if we want to go by the evidence shows that many physicians prefer to use furosemide, probably out of the convenience, but regardless. So are there any differences between the three of them? When I was in medical school, I always hated when a professor put a busy slide and pretended he knew everything about that. I don't do that myself. I don't know all these numbers, and I don't know every detail of this slide, but I want a couple of things to be highlighted. Number one is the bioavailability. Third row, if you look at it, furosemide is 10 to 100. When somebody tells you the bioavailability of a medicine is 10 to 100, what is he trying to tell you? I don't know the bioavailability. 10 to 100? Pick your number. But look at the Bumex or bumetanide and torsemide. 80 to 100, 80 to 100. So keep that in mind for PO medicines. We don't really know the bioavailability of furosemide. And there are other aspects in this slide that are interesting, but I think I should pass. Just look at the half-life, that the half-life of furosemide and bumetanide are lower than torsemide. That's why typically we use torsemide once a day, many of us, but the other two, twice a day would be a better option. One last question for you. When you start a patient, let's say on furosemide, what is the dose? What dose is good? Here it says start 10 to 20 or 5 to 10. Initial outpatient period 5 is for torsemide and 20 to 40. Just keep that in mind. We really don't know the conversion between furosemide and torsemide. Most of us, we go to 1 to 2. More and more studies are coming to tell us it is 1 to 4 actually. We might have been giving a little boost to our torsemide, not knowing it ourselves. And the most recent paper is by Testan in Jason, if you are interested in looking at it. So a big trial, Transform study, around 3,000 patients, it couldn't show a difference between torsemide and furosemide. And you know what? We can go to the mumbo jumbo of nephrology. But common sense tells you, if a medicine has been around since 1960s, and to this date you don't know which one is which, you should probably give up. This study technically tells me this. This is their primary outcome. There were a number of secondary outcomes. None of them, torsemide was better than furosemide as we thought. These were outpatients, so they had acute heart failure. They went out and they changed it to torsemide versus furosemide, and they followed them. Keep that in mind, however, in this study, actually it's beautiful, the discussion. If you go and read it, it tells you we told the physicians to pick their conversion, 1 to 2 or 1 to 4. Okay? If they had picked 1 to 4, it seems that torsemide was on the lower side of efficiency. So as opposed to what we thought when we went into this trial, torsemide might not be as good as furosemide based on just what you look at it. Again, you look at the diagrams, they are the same. So based on this study, they are the same. For me, nephrologist, I go and look at the subset of patients with CKD. What about those who had CKD? Was there any difference between furosemide or torsemide? The answer is no. There is not even a trend. So again, it tells us between furosemide and torsemide, it has not been shown, let's say, if there is a difference or not. So if you want to summarize what I just told you, most patients with chronic heart failure require a maintenance dose of loop diuretic. Furosemide and bumetanide have a short acting, while the other one is longer acting. And torsemide and bumetanide have better and more predictable bioavailability. The list, I think the ideal choice of loop diuretic remains to be just elucidated.
So if you're increasing the dose of torsemide in this patient with heart failure and CKD and you find inadequate decongestion with that strategy, what would be your next best step to enhance decongestion? Would you add an SGLT2 inhibitor like empagliflozin? Would you add a carbonic anhydrase inhibitor like acetazolamide IV? Would you add metolazone? Or would you admit your patient to the hospital for IV diuresis? Let's see your choices.
Just give you a tip. This one has a better answer for a change.
Okay, so there's a favoritism towards metolazone, which makes sense. This patient's eGFR was markedly reduced. I must say that I would not have necessarily stopped the SGLT2 inhibitor when the eGFR initially declined. And at this stage, I would have chosen metolazone as an adjunctive therapy, aside from increasing the dose of the loop diuretic. Now, here is something we published about strategies to decongest patients who were being managed either in an ambulatory IV diuretic setting or in a hospital. So the first step, assess for evidence of congestion. And you do this both clinically, and you can also do this looking at biomarker changes over time and assessing for other parameters in the labs and your imaging modalities. As an initial step in somebody presenting with heart failure, always consider adding those therapies that improve long-term prognosis. You can initiate them up front safely, so SGLT2 inhibitor and MRA, and then a loop diuretic, which is the mainstay of therapy to diurese patients. This could be any of the loop diuretics we discussed. And in a patient who has an outpatient dosing of oral diuretics, you can convert those to an IV regimen by doubling or going 2.5 times the baseline oral diuretic dose. If they are diuretic naive, you may start a low-dose IV diuretic and then assess the diuretic response, not in 24 hours, but in 2 to 4 hours subsequent to that IV diuretic bolus. And you could do this objectively by assessing the urine sodium with the spot urine sodium test, and also by looking at the urine output and their clinical response. If the urine sodium is low, so less than 50 to 70 milliequivalents per liter, you know that the diuretic strategy has been inadequate. So then you can double your IV diuretic dose and reassess for decongestion again 2 to 6 hours thereafter. If the diuretic has been adequate, you may repeat that same diuretic dose. But if the diuresis has been inadequate, then think about sequential nephron blockade strategies by adding adjunctive diuretics, such as acetazolamide. Now, in the trial that tested its efficacy, patients had a daily dose of less than 80 milligrams of loop diuretic. So if your patient has high diuretic requirements in the ambulatory setting, I might not add a carbonic anhydrase inhibitor as a first step. But other choices could be a thiazide diuretic based on the chlorotic trial or metolazone. There was a trial that compared dapagliflozin 10 milligrams to metolazone 5 to 10 milligrams daily, and there was no change in the primary endpoint. But among the secondary endpoints, there were some signs that metolazone was more effective at decongesting patients. And so this is the strategy to optimize diuretic in the acute setting. But Amir, perhaps talk to us about the ambulatory setting and some of the strategies that are currently either evidence informed or under investigation?
Sure, absolutely. I'll be happy to. And before I start with that, I just want to reiterate the fact that the combination diuretic therapy is kind of a standard of care when you see that the things are not in the right direction. This would be number one. Number two, what Harriet said is super important, the urine sodium. How many of us have a patient with hypertension? We start them on amlodipine or lisinopril. We do not check the blood pressure anymore because the patient is already on antihypertensive. None, right? How do we start a patient on a diuretic? We don't check the urine sodium to see how effective we are. Keep that in mind, urine sodium, as she said, is really important. I would do it very often if the hospital has the resources and it's not an expensive test. So back to combination therapy. This slide shows us the 5 possibilities of adding something to our loop diuretics that are the cornerstone of therapy. I don't go into the details, obviously. You have all the studies that are there as much as the evidence is. But something that I want to just recognize here is carbonic anhydrase inhibitor. They have become a little bit of a new hype, and all those, the Belgian group wrote a lot about it. And it was published in New England Journal of Medicine, got a lot of attention. Having said that, as a nephrologist, I just want to warn you that they deplete potassium. You want to start them when your potassium is 4 or above. And they are actually the ones that the thinking has been changing from sodium centric to maybe chloride is the important one. Because the minute you start them, the chloride will go up, the bicarbonate will go down. So keep that in mind. The rest, SGLT2 inhibitors, I think Harriet mentioned very well, they have the added benefit of when you start them as a diuretic, it will probably will continue for after discharge, so the patient will get the benefit at long run of having SGLT2 inhibitors on board, as you know. Okay, so there is a study that tried to answer the question we just had together. So a patient is coming with worsening heart failure, not bad enough to be admitted to the hospital. What should I do with this patient in the, let's say, the transitional unit I have or ambulatory unit that I have? They looked at IV furosemide plus acetazolamide, and IV furosemide versus piometolazone. They tried to compare these 3 regimens in these patients. And guess what? When they looked at the urine sodium, urine volume, and weight difference, what they saw was that furosemide and metolazone were probably the best in terms of getting more sodium out as well as bringing down the weight. And something, again, in this study was interesting is that acetazolamide had pretty much no impact on anything. At least in this trial, if you look at it, it is very close to furosemide alone, both in terms of the sodium extraction and the weight difference. So that is something interesting. So what you answered, 50% of you answered, I think metolazone is the right answer. I go with that as well. Again, reminding myself that metolazone gives major hypokalemia. I would be really worried about that part. I make sure that the potassium is on the higher side when I start it. So what about worsening renal function? Does it give what we call worsening renal function? I know that worsening renal function in acute heart failure, all of us is old news. We know that it is not impacting the outcome, and if it impacts, probably it is favorable. So we are not worried about that part. What about the outpatient? There is one study that came last year. It showed that up to 40% decrease in GFR is actually acceptable if your congestion is getting better. I just want to mention that being a nephrologist among a number of great cardiologists, I wouldn't worry too much about the creatinine going up if the patient is being decongested, whether outpatient or inpatient.
So if this patient calls on a Friday evening, as is the norm, for worsening congestion, what at-home strategy can be used to avoid an emergent visit?
Excellent question. We didn't have much data up until recently. Now we have options that we didn't have. Number one is the sub-Q furosemide delivery system that has come. It's an infuser, as you see. It's not big. It's the palm of a hand. You put it there, and it gives you 80 milligram of furosemide subcutaneously in about 5 hours. It gives a 30 milligram first in 1 hour, then 12.5 milligrams over the next 4 hours. So does it help? Is it helpful or just another medicine going under the skin without much evidence? I don't go through how they did the trial out of the interest of the time, but remember that this is a phase 2, only 51 patients, but it was a 2-to-1 randomization. So twice got sub-Q furosemide compared to those who got usual care. Again, a patient with worsening congestion in the outpatient. What should I do with them short of sending them to the ER? The answer was, I have only 3 slides, but I can tell you a little bit more about it. In at-home heart failure, when they look at it, you see the purple color is the sub-Q furosemide. You see that there is a trend towards better body weight. The body weight comes down better than the PO, right? So this is a trend, but it was not statistically significant. But I have also to say that, first of all, the good news about this study was that the GFR baseline was around 50 something. These are CKD patients, right? They didn't plan for it, but that's how it happened. And 1/3 of the patients had CKD. This is the common heart failure population. Number 2 is that the number of patients were low. If it was a higher number, you may have seen the statistically significant effects that you see here. Number 3 that I want to add is that in this study, dyspnea got better with sub-Q furosemide. So the patient subjectively felt better, especially within the first few days of using it. And a newer paper came out just last year. They looked at patients who had diuretic resistance versus no diuretic resistance during the previous admission. They came out, they randomized them, and those patients who received sub-Q furosemide, they did better. So if I have a patient with diuretic resistance or either the history or risk factors for it, I would be really considering sub-Q furosemide versus PO if the patient starts to have congestion. There is another, I would say, approach or another option, but this is much newer. It needs to be validated. It's intranasal bumetanide. This is a study of PK/PD of the intranasal bumetanide. In the interest of time, I pass on it. I just tell you that in terms of pharmacokinetics, it was slightly better than the PO, and in terms of pharmacodynamics, it was close to IV bumetanide. So there might be some truth to it. We will know it later when the larger studies come.
Right, and another application of sub-Q furosemide that we adopt in Canada is for palliative care. So end-stage heart failure where patients have high diuretic requirements, but oral diuresis is not adequate, and it becomes less feasible to put in IVs or indwelling catheters to give patients intravenous diuretic. We use sub-Q strategies. So how do we integrate care? And there are many different models of care that facilitate outpatient diuresis, either sub-Q or IV or high oral diuretic requirements. And this involves partnerships between cardiology, our friends in nephrology, who we were quite siloed from until recently. We're now kind of working more as a team, but also nurse clinicians, advanced care practitioners, and pharmacists to provide different ways of delivering frequent care without relying on specialists alone. We know that in certain implementation trials, nurse-led models of care, pharmacist-led models of care enhance the patient's experience of care, and following algorithms can ensure quality assurance. What kind of models do you use?
We actually have a cardiorenal clinic at the University of Florida that we work with our heart failure colleagues to just hopefully improve the care of the patients.
So let me just say that many collaborative care models exist. Funding often is the limiting step in the delivery of care using such models. and this varies across healthcare systems. Key takeaways from our session: congestion requiring diuretic intensification is associated with an increased risk of death. Decongestion strategies should focus not only on helping the patient feel better, but also live longer. Using guideline-directed medical therapy is a sure way for ensuring this outcome. Loop diuretics are the mainstay of decongestion. They can be administered orally, intravenously, subcutaneously, or intranasally. Add-on diuretics can enhance decongestion, but they don't improve clinical outcomes. Thank you all for being here. I hope you get a second round of breakfast, and we're open for a little bit of discussion maybe.
Thank you.
Before we all leave. So, questions. We don't have any audience questions. So that makes our job easier, and I'm not sure if we have time for an audience. Oh, I'm getting the off sign. So, on that note, we thank you all for being here, and we'll see you in the hallway for more discussion.
Thank you very much. Thank you.